Hi, we are Team 5 and this is our presentation on the Ebola outbreak in West Africa from 2014 to 2016. So what is Ebola? Ebola is a fatal zoonotic viral disease that often has outbreaks in Africa. It spreads through direct contact such as blood, bodily fluids, and animal tissue. The virus can then be transmitted through bodily fluids of others that have been infected or those that have died of Ebola virus disease. Symptoms of Ebola virus disease include fever, aches and pains, weakness and fatigue, diarrhea and vomiting, abdominal pain, unexplained hemorrhaging, bleeding, or bruising. This image explains the ecology and transmission of Ebola virus disease, or EVD. EVD outbreaks begin with animal-to-animal transmission. It then can spill over to humans when they make contact with an infected reservoir host. Humans can then infect other humans in ways mentioned before. The virus is fatal, however, survival is possible. Many survivors experience symptoms such as fatigue, muscle aches, and face stigma. Description of the outbreak. The Ebola outbreak of 2014 through 2016 in West Africa began with a young boy who was said to have been infected by bats. On January 24, 2014, a medical alert was issued due to 5 new cases of fatal diarrhea. The virus quickly spread throughout Guinea and to its capital, Conakry. This is largely due to a poor sanitation and a poor public health infrastructure. As mentioned by the Center of Disease Control and Prevention on March 23, 2014, with 49 confirmed cases and 29 deaths, the World Health Organization officially declared an outbreak of EVD. Ebola virus was then officially declared by the World Health Organization as an outbreak in Guinea. This map is a clear representation of the outbreak in West Africa. While most cases were concentrated in Sierra Leone, most deaths caused by EVD were in Liberia. To touch on the historical context of the disease, Ebola virus disease is named after the Ebola River in Zaire. EVD was discovered in 1976 after it first emerged in Sudan and Zaire. There are 5 species of Ebola: Sudan Ebola virus, Zaire Ebola virus, which is the most fatal and associated with the 2014 through 2016 outbreak, Reston Ebola virus, Thai Forest Ebola virus, and Bundi-Bugyo Ebola virus. Sudan, Zaire, and Bundi-Bugyo are responsible for the larger outbreaks in Africa. This map of Africa displays Ebola virus outbreak by species and size since 1976. As you can see, the larger dots are concentrated in West Africa.
What was the world population and the US population of the 2014 to 2016 Ebola outbreak? After the Ebola virus was officially declared an outbreak by the World Health Organization in Guinea, it quickly spread across the world. The Ebola virus outbreak quickly spread to Guinea's neighboring countries of Liberia and Sierra Leone. By July 2014, it had spread to the capitals of the 3 countries. The World Health Organization declared Ebola virus an outbreak in West Africa a public health emergency of international concern on August 8, 2014. The 2014 to 2016 Ebola epidemic spread to 7 more countries: Senegal, Mali, Nigeria, Spain, Italy, the United Kingdom, and the United States. Ebola in the United States. During the outbreak of the 2014 to 2016 Ebola outbreak, 11 people were treated for Ebola in the United States. The first case brought to the US was on September 30th, 2014 by a man who had recently traveled to from West Africa to Dallas, Texas. The 2 healthcare workers who attempted to treat him also later tested positive for EVD. While the 2 healthcare workers recovered, The patient later died on October 8, 2014. The other 8 were medical workers in West Africa. Of these 8 individuals, 7 of them recovered while 1 died. The World Health Organization lifted the PHEIC status on West Africa's 2014 to 2016 Ebola virus epidemic on March 29, 2016. The 2014 to 2016 Ebola outbreak in West Africa killed more people than all the other known Ebola outbreaks combined.
The impact that Ebola had on the population of West Africa. The World Health Organization reported the first case of Ebola in West Africa on March 23rd of 2014. From there was a steady increase in cases, with a large spike around November of 2014. From then on, there was a slow decrease in the amount of new reported cases until the last reported case on June 10th, 2016. During the span of the outbreak in West Africa, there was a total of 28,616 cases and 11,310 deaths. The Ebola outbreak in West Africa impacted these populations in many ways. Guinea, Liberia, and Sierra Leone had substantial economic loss in agricultural product, which caused the population to become worried about their food security. There was also restrictions placed on cross-border trading, which added to the economic loss. During the outbreak, healthcare workers were at high risk of contracting the disease, and because of this, Liberia lost 8% of its healthcare workers, while Sierra Leone and Guinea lost 7%. Due to the epidemic, there were setbacks with treating other illnesses such as HIV, tuberculosis, and malaria, which added to the mortality rate of West Africa. The Ebola outbreak greatly affected children. Around 20% of cases were those of children under the age of 15. The epidemic also caused an estimate of more than 17,000 children to have been orphaned. West Africa closed their schools from June 2014 to 2015, causing children to lose many hours of education. During this time, there was also a 30% decrease in immunizations among children due to the vaccine campaigns being postponed.
Response to the outbreak. The CDC, Centers for Disease Control, has played a vital role in the response towards the Ebola outbreak in West Africa from 2014 to 2016. According to the article, 2014 to 2016 Ebola outbreak in West Africa, posted on the Centers for Disease Control website, the following are examples of how the Centers of Disease Control responded to the outbreak. The CDC activated its Emergency Operations Center to help provide technical assistance in terms of data management, testing, spreading awareness through health education, and tracing contacts. To limit the spread that could have occurred through travelers coming into or going out of West Africa were required to be screened. Tracking those that were at potential risk of having the disease helped limit the spread from West Africa to other countries. The Center of Disease Control put in an extra initiative to train additional healthcare providers to assist during this outbreak. The CDC recorded to have trained approximately 24,655 providers to be able to have further trained in infection control and prevention practices. According to the article, final trial results confirm Ebola vaccine provides high protection against disease. Posted on the World Health Organization's website, the cultivation of a specific vaccine showed to have a massive contribution in becoming a protective source against the disease. How the vaccine came about. It was through the partnerships between local organizations like Guinea's Ministry of Health
and Norwegian's Institute of Public Health that work together with international relations under the WHO, World Health Organization, to conduct trials and comparisons for the newly created vaccine called RV-SV-ZBOV. The RV-SV-ZBOV proved to be successful in its trials and reported to have had fewer cases after its distribution. Response to the outbreak in the United States. According to the article titled U.S. Response to the Ebola Epidemic in West Africa, under the presidency of Barack Obama, the U.S. had joined forces internationally, including with the United Nations, to help stabilize governments affected by the outbreak. Steps the U.S. planned to take to control the spread. Enforcing regulation and precautions in West Africa to control the spread at its origin. Making an effort to lessen the impact of second-order impact on government, finances, social and political structures. Working with other countries on a global level and protecting global health.
As the security of global health is heavily reliant on countries being able to detect and control public health threats at the source, risk communication becomes a key tool to educate the public and promote early medical care. According to the CDC's report on EBD-specific knowledge and behavior during the 2014 outbreak, about 88% of persons surveyed reported that radio was their main form of receiving Ebola information. Religious leaders and educational campaigns were also shown to be essential. The use of CAP surveys as a way of measuring persons' knowledge and self-reported behavior in relation to disease provides pertinent data on the effectiveness of risk communication. The data from these surveys showed a strong association between citizens being accurately exposed to information and exhibiting protective behavior. Despite the strongest positive association with radio, some of the weaker associations can be attributed to contradicting messages during the outbreak. Misinformation during outbreaks can be fatal, as people can begin to reject proposed interventions later on. While other research shows contrary information as to whether or not knowledge is needed for behavioral change, the CDC supports the evidence that information is crucial to the negative or positive outcomes after an outbreak. When evaluating the communication to U.S. citizens regarding the 2014 outbreak, the direction was much different. Despite a low risk for the outbreak to hit the U.S., the infection of 2 U.S. clinicians being treated in the States led to increased residential fear. This resulted in the CDC releasing mass communications to slow the spread of anxiety and misinformation as rumors about disease presence and transition began to flow. The rapid and deadly spread of the disease in West Africa contributed to the increasing belief that the epidemic would make its way to the U.S., causing some states to impose drastic quarantine restrictions on citizens returning from countries hit by the disease. This, in combination with falsely reported stories about the disease spreading in the U.S., caused the CDC to introduce a campaign of infographics, social media chats, public service announcements, podcasts, and other interactive inquiry settings. When examining improvements needed in risk communication, it is clear that routes of information need to be properly adjusted for each population. It is also pertinent that new threats are addressed before anxiety begins to incite mistrust in fact-based interventions. This will require a multidisciplinary approach using behavioral and communication sciences along with progressive public health promotion. Among these key lessons learned, we now know that West African countries are in need of effective monitoring services to protect against infectious disease threats, that risk communication must be accurately and promptly disseminated to improve health behaviors, and that it is through partnership between different organizations and international relations that can assist in the creation of an effective and timely vaccination through the use of trials and data comparisons.
And these are our references. Thank you for watching, and let us know if you have any questions.